Hello, everybody. Welcome to Fertility Fact or Fiction, our weekly show where we share with you the very latest and greatest in all things fertility. And when that's not available, we come up with a debate topic, which is tonight's topic. We are going to talk about whether or not fertility centers should be owned or partially owned by businesses, venture capital, private equity. Who should run your fertility business or fertility practice? And can it be run as a business, or should it be just purely medicine? And so we're going to talk about that tonight, talk about the risks and the benefits and the pros and the cons. And it's all from input from you guys. We're going to make a pro and con chart, and I'm certainly happy to weigh in with my opinion.
All right, I got one, Habibi.
I am here with my dear friend Tariq Ibrahim from Ibrahim Strategies Group, and it took us forever to get dinner, but we did get some phenomenal food. So we don't do advertisements here. We don't do any support stuff. I'm not paying anybody, and nobody's paying me to talk about them. But I will say that we ate at a place called Yemen Stars, and the food is phenomenal. So if you live near here, whether you're in Michigan or you're in Windsor or Chatham or even London, this food is actually worth coming for. It is amazing, amazing food. It's Yemeni food. It was phenomenal. So Yemen Stars, try them out. They're on Wyandotte Street. Did you get the address? I didn't actually pay attention to the address. But try it. Yemen Stars, phenomenal food. We couldn't stop oohing and awing about it. So amazing, amazing stuff. There were some interesting articles out there, but we kind of brought up this topic last week. For next week, we will have a topic about various uterine fusions and which of those is beneficial and which are not. And I'll review the HCG wash, Newton, PRP, all that. And we're going to talk about how those may or may not benefit your cycle. But this week, we're going to talk about the debate. So the reason this came up is because there is a big movement throughout the world to move towards businesses investing into fertility centers. Let's all be very clear. Fertility businesses make a reasonable income, some definitely more than others, and some of the really big ones make a huge amount of money, and so they are worth a phenomenal fortune. And so businesses have realized this, see it as a constant stream of revenue. Right now, it's 15% of the population. Estimates are that infertility will affect even more people subsequently. And so they are all the business people are looking at this saying, this is a great opportunity. We've got loads of people who need this service. We've got loads of people who, are going to be kind of a captive audience. Most of these people are quite desperate and they will spend a lot of money to make this work. So why not dip into this, resource pool? And so as a result, there have been businesses that have been sold. So I don't want to get into names because I'm not sure that that's doing a service to anybody. But for example, one specific chain of fertility programs in the US sold for just less than $1 billion a couple of years ago. That's how valuable these businesses are. There is currently a move within Canada to also start snapping up fertility clinics and amalgamate them into kind of one umbrella. They may have different names, but they're under one umbrella operation. And then there are those of us like myself who don't know anything and have our own practices, and we run it privately. So my question for you guys tonight is, how do you feel about the idea that your fertility physician and clinic may not actually be wholly owned by a doctor? What if it's owned by a venture capital or a private equity where they are coming in and investing money into the process, and they are saying, we are going to put in $5 million into your business and we get to control how it's run. I now become an employee. And I've had offers. I mean, we've had multiple offers to buy VRC before, all for a minimum of 51% for literally huge sums of money, which I am 100% not interested in doing, but I want to know what you guys think. I am super curious to know What do you guys think? How do you feel? What would you do if you knew that it was actually not a doctor that was making the decisions of what media is being used and which equipment should they use and what goes into a package and what should be used and what should be charged for and those sorts of things? What do you guys think should be the input? So I want you all to throw up your comments regardless of which platform you're on. If you're watching us on TikTok or YouTube or Twitter or Facebook or Instagram, it doesn't matter. I want all of you to give me loads of feedback to tell me what you think is important here. Is it okay to talk or to own a fertility practice if you're not actually a fertility doctor? So what do you guys think? Give us some input. Did anyone comment yet?
Nobody commented yet.
Oh, wow. Let's see if people say things. Last week we had a similar kind of debate about a different topic, and there was loads of good input. And so it was whether or not it was okay to make babies from 3 different sources. So we talked about that last week. And so now I want to know, what do you guys think about your fertility center not being owned by a doctor? I'll start it off by asking a question, I guess. So, if the decisions that are related to quality of supplies, equipment, the stuff that we use are not being made by a doctor, how do we know that they're the right decisions? How do we know that the decision isn't being made for, financial reasons and not for what's best? We, for example, realized from this show that embryo glue works. It's very clear that embryo glue works. And so we include it for free in every single cycle and every single embryo transfer that we do. It's being used for everybody because, in my opinion, it's unethical not to. If we didn't use it, we would be doing a disservice to our patients. So we just included it. It doesn't actually cost very much. And so I said to myself, this is a no-brainer. People should be getting access to treatments that they need as part of their fertility cycle. And I made that as a medical decision and B, a moral decision. But if I was making it from a business decision, I would have said, well, yeah, it's better. So why aren't we charging people for it? So we got one here from Jess. I don't think you should own unless you are a doctor. How can... Oh, it ran away.
I can read it for you.
Can you read it?
Yeah. So I don't think you should own unless you're a doctor. How can you run a practice that you aren't deeply educated in? I feel they are in it for the money and not for us.
Yeah.
I would never trust the fertility clinic because the patient is no longer the sole focus. It depends on how much they charge your operations. If there is a degree of physician's input you're comfortable with, that may be okay. However, it can really mess up incentives and hurt patient care. I would feel like a walking dollar sign.
Yeah, and I that's what worries me too. I mean, I'm worried that we're turning people into dollar signs, right? And I do think it compromises the quality of care. And again, I don't want to get into specific clinics, but the reality is that this is very prevalent in the US. It's becoming very prevalent in Europe. I saw it when I was in the UK. They have these conglomerates that are just buying and buying and buying. So much so that there is a UK clinic that's now moving into the US and buying up US clinics. So, what is the motivation? Like, when I'm helping people working 24/7 and here till 9 o'clock at night and then taking calls after the show and then sitting down to answer everybody's Instagram questions, I'm doing that because I want to help people. But if people are doing it for a business reason, I got to wonder, are they providing the same level of care? I work at a clinic as a nurse in management, and our board of directors are not from the healthcare. It would seem they see how expensive fertility is and take advantage of us for having to pay. Well, now there's tons coming up on TikTok. You're going to have to do them because I can't read them all.
My God, my hormones would have me saying, well, who the heck are you to give me any advice?
Oh, see? I mean, that's a good one.
Depends how much they charge. Oh, hold on. I will feel like I'm a walking dollar sign. It would be better if you just flushed your money down the drain. Question, are these clinics usually more expensive?
Well, I can tell you that I know of a chain that are being amalgamated under one company right now, and I don't know the prices of all of them. I don't believe that they're any more expensive, although I do believe the prices have gone up compared to where they were before, because you got to remember that the goal of any business is to generate revenue. And if it's venture capital or private equity, what they're also probably looking at is, how do I make this business really profitable, because I want to sell it and take my profits and run and do this again somewhere else, right? So they're not looking to buy into it and just sit there and collect an extra $5,000 or $10,000 or $100,000 a month. They're doing it because they want to take a $1 million business and sell it for $5 million, and then take their $4 million of profit and invest it into something else where they can grow it even more. They're not looking to take $1 million of their money, put it in, and then every month get a return of whatever, $10,000, because it's going to take them 8 years to get their money back. No one wants to do that when they're into big business, right? So the whole idea behind these companies is to generate a model in which you are getting your costs as low as possible and your margin as high as possible, so you can demonstrate a lot of profit, so that when you turn around to sell the company, whether it's one clinic or 10, it doesn't matter, the buyer looks at it and says, oh, they're making 60% on each cycle. So if the cycle costs 10 grand, they're looking at it and saying, these guys have got it down so good that it's only costing them whatever, $5,000, and $5,000 is profit, or it's costing them $7,000 and $3,000, whatever the numbers are. But they want that margin to be as big as possible, so that when they turn around to sell it, the company's worth a lot, right? Because now the buyer looks at it and says, oh, between all these different clinics, they're doing 1,000 cycles, they're making, $5,000 on each cycle. That's $5 million in a year. So now I can see that if I invest into this and I buy it, I'm making a lot of money. And so that's why these companies are trying to do it, because now they're taking their small little company and they're making it into a much bigger company that they can sell to somebody else at a huge profit, like huge, enormous, right? Right now, if you have a fertility clinic that has more than one laboratory site, so IVF lab, you're looking at 15 to 20 times the EBITDA, which is income before taxes and what's the other thing? Income before taxes, something. I'm not an accountant. So you can make an enormous amount of money, like literally huge. If you're making $5 million a year in your EBITDA, you're worth $75 to $100 million. We're not talking chump change here. It's an enormous amount of money. So again, when you look at that, yes, some of these clinics are increasing the prices and by necessity driving down the costs. How are they doing that? I don't know, because I can tell you personally, my costs go up every minute because of the fact that we're constantly hiring more people. We're constantly buying new equipment. I just got my second time-lapse embryo scope. So now we have the two of them, plus all the other incubators, plus more space. We're adding 12,000 square feet. It's not like my costs are going down, but I'm keeping my prices the same because we're trying to keep that fair for everybody and provide the best service that we can. If I make a little less, but I'm doing a better job for people, to me, that's what's really important. But when you're a business, you can't live with that model. It just doesn't work. So what are some other comments? I
don't agree with this. Coming from the dental field, that's what has turned very corporate. I feel it is no longer what is best for the patient, but becomes about what is the best for the corporation. I won't trust them as it's health-related issues, so I would only trust doctors and not any business. There's also a risk to increasing staff burnout and reducing appointment time, etc., for efficiency.
Right.
This can often impact patient experience in addition to clinician experience.
That's huge, eh? Yeah. I mean, are you on a clock? Are they telling you need to meet quotas? You gotta, hit these targets. You've got to make sure that you see 20 people a day instead of 15. So you got to squeeze in more people. And I mean, I see, 50 people a day, but you know what I mean, right, guys? So am I trying to cram everybody into this just to generate enough revenue? And are they then telling you, like, seeing patients is not the end of the world. Work a couple of extra hours, see more people, whatever, that's fine. I'm not scared of seeing more people or working harder. But what if they turn around and they say, look, we really need to push the IVF because that's where we make our most money? Because it is. Like, I'm open about this stuff. And if they start saying, well, you only converted, because they have a term called conversion, which is the number of patients you take from basic fertility and transform into IVF patients. So maybe they're going to say you need to get your conversion rate higher. I mean, I don't feel comfortable with that. For me, I need to make sure that I'm just doing the right thing for the patient. So when patients come here, we always tell them, you can have this, you can have that, you can have that. What would you like us to do? Sure, there are some circumstances where certain things make sense. If you've just got PCO, I would never tell you to jump into IVF. It just doesn't make sense. You should try all the natural stuff, the letrozole or Clomid, getting your body in shape if weight's part of the issue, having regular intercourse, making sure your periods are regular. If that doesn't work, then maybe we would try IUI. And then if that doesn't work, yes, of course, we would go into IVF. Conversely, if your tubes are blocked, you have to do IVF. There's no choice, right? We know that. But for all the other patients who kind of fall in between, we always focus on giving you all of the options that apply to your scenario and then letting you choose. So, if someone was above me because I sold half my company and said, Victory, you're only converting 10% of the patients to IVF or whatever, 15%. We really need your target to be higher. Now I'm feeling obliged to tell people, you could do letrozole and the natural stuff, but why don't you just jump right into IVF? Here are all the advantages and benefits. And it's not that those advantages and benefits aren't there. It's not that anyone's lying to you, but it's all a slant. Right? It's how I pitch it to you. If I tell you, well, you get the benefits of this, that, and the other thing from doing this treatment versus the other one, you're going to listen to me because I trained for years to do this and I'm a doctor and people tend to listen, or at least they used to their doctor. What are people saying?
They're saying, actually experience it firsthand. They don't care much about your personal case. Pretty much same protocol for everyone.
Oh.
They will try to push to do the egg retrieval and transfer the embryo. If you fail, just do another round.
Yeah.
Just feel so disconnected and neglected. Actually switched the clinic for that reason.
Amazing. Yeah. I mean, that's terrifying.
There's more. If there is a need for cash flow from investors to maintain services remain open, then okay. However, there should always be physicians involved in overseeing all of the policies and decisions related to care and patient care. Ultimately, the physician should always have majority in all of the day.
So, listen, I don't know about the specifics of every organization out there, but of the ones that I know, again, without mentioning names, I know that there is only one that actually has the physician owning 51%. You got to remember that no venture capital or private equity or investor, for that matter, is going to want to give up control because what they want is to make it as profitable as possible. So how this one individual wrangled this, majority stakehold in their own company, I don't know. But, that's a big question. I don't know how people are supposed to manage that and decide what the right thing to do is. Like, how do you decide? And here's a bigger question. Should clinics be declaring who owns them? Should we have a sign on our front that says 100% physician owned? I would love to know.
When healthcare turns into a sales pitch, it's not okay. Thankful for the personal care you give.
Oh, thank you.
I found, what is it? It's important to look at the healthcare sectors where this has happened to see impact on efficiency, clinical burnout, patient care, etc.
Yeah, that's a good point. I mean, I don't know. The only one I know of is dentistry, where there was a similar model and they made billions off of it, and I have no idea what happened to the quality of the care. Who knows? Like, I'm not saying it doesn't improve. Maybe it improves. It's a debate. I can see some advantages. Uniformity. If you own 5 clinics and one clinic isn't performing as well, then you're going to do better when you have everybody realize, oh, like clinic 1, 2, and 3 are doing really well. They're getting a 60% success rate, but clinic 4 and 5, they're only getting a 45% success rate. Let's look at what they're doing and bring them up to the level of the first 3. So maybe there are some advantages in there where this would benefit some clinics, but if you have a weaker clinic, yeah, I can see how it would pull you up. But if you have a stronger clinic and they're telling you to make decisions based on cost, I guess it could pull you down. And yeah, it depends on how much they decide to interfere. If they come in and say, look, we're going to do promotion and marketing and sales, and we're going to train your staff, and we're going to teach people how to be more polite on the phone and stuff like that. Okay, I can totally see how that's beneficial, right? But if they come in and they say, look, we love what you're doing, you're making loads of money, but let me just ask you a question. You're using this needle, and this needle costs $50, but we can get you this needle for $25. Why don't you start using that needle? Well, what if that needle isn't good enough? I tried a different needle today because a supplier told us that we should try this new needle. I'm still getting used to it. I don't love it. I kind of like my old needle. Creature of habit, yes. Am I habituated to the needles I've been using for 20 years now? Yes, of course I am. But, it's going to save me like literally more than half the cost. But I'm not going to make that decision if it's not as good a needle. Because I don't care about the money. I care about the quality of the care that I'm providing.
I found your price list so different from a previous clinic I was at, in a good way.
Oh, cool.
So many things are included in your price. At my previous clinic, we were told this is better but costs more. Yeah, of course.
Yeah, I mean, we don't even include all the stuff we do on our price list. So time-lapse embryoscope, I don't actually know of any clinics that include it. As far as I understand, everybody else is charging because it is expensive. We pay a fortune for it, and we don't charge for it. Like, we literally don't charge for it. It's just built into your package price. We take a loss so that we can provide you with better care. Same thing with the embryo glue. And people are getting gouged on embryo glue. Embryo glue is not expensive. So for what it would cost us to just include it for everybody, it was well worth just buying it and putting it into every single embryo transfer. Because for the amount I'm losing, I would happily lose that if I know that it's going to improve your success. And I think that's the way this should be. I mean, obviously there's a limit. If you guys came in and said, well, why aren't you including intra-ovarian PRP, and why aren't you including PGT, and why aren't you including this and that? I mean, there are some financial limitations. We can't include everything. But I'm not making my decisions purely based on finances. I'm first making my decisions based on the quality of the care that we are providing you and what's right, medically speaking. And then I'm doing it based on, how does this look for VRC and for you as our patients.
Infertility is so hard emotionally, physically, and financially, and it just seems like profiting off people's heartache. From a business standpoint, it's smart, but it just feels icky. It's super icky.
So Jess is asking, do we include embryo glue with our funded transfers also, or only private pay? It's in every single transfer. There are clinics that try and modify their protocol for funded cycles because they don't want too many embryos. They don't want a gargantuan number. They don't want to have to be responsible for freezing all those embryos, for storing all those embryos, for managing them, and potentially for having to transfer. If you came in and said, I want 5 kids, we're losing money. Like, there's no question. If somebody makes more than like 3 or 4 children from a funded IVF cycle, we're taking a loss. Okay. I want that very openly known. We are losing money at that point on those cycles. So in that situation, I think it's critically important to recognize that you either decide to do the right thing and treat everybody the same way, or you make concessions for the ones which are going to cost you more. We don't. So that's not something we are doing. Jess, in March of this year, you should not have been charged for embryo glue. So let me know and we will refund you, because we already had that as part of the package. So come back in. If you paid for it, and we will happily refund you. Come back in. We've been doing that for a long time. Last year we were charging, but that's because the price of our package was ridiculously low. We then increased our package price, and we have included it since then.
If your patient has a successful laparoscopic surgery and endostesis, that's the question. Hold on. Before we go into the questions, just on
more comments.
Yeah. All your comments about not using birth control to schedule an increased volume. No, not yet. Oh yeah, actually, yeah.
People are starting the questions now.
All your comments about not using birth control to schedule for increased volume and efficiency is one example. Would you be able to make a decision that decreases efficiency without it being a problem?
Yeah, that's a great point, right? Like, you want to make it more efficient. People have holidays. You want to minimize the staff needing to be there. You need an embryologist to jump between clinics. You're going to put people on the birth control pill. That's not the best way to treat the patient. So that's a problem. Yeah. That's hilarious. Oh, hi, Jess. It's Jessica again.
Yeah,
I see that.
Uncle Rahi. I'm hoping there's an Uncle Rahi.
Yeah. Imagine, LOL, welcome to Nike Fertility Clinic. Free pair of runners with every embryo transfer. That actually is quite funny. Yeah. I don't know, guys. I worry about the compromising care. I think it could be fantastic. So I want to show the positive side of this too. It's not all negative. There could be someone well-intentioned who says, look, we can create a better model. We can provide people with better care. We can invest into your clinic, make you bigger by virtue of providing better care. So instead of let's, cost less and let's charge more, it could be, well, you might make 10% less, but we're going to increase your volume by 40%. So you're still making a lot more overall. And that model I believe in. I think that's a great model, and that's kind of what we've been doing. So for me, that makes a ton of sense. Let's charge people less. Let's give them the very best care that we can. But let's use that model to generate more patients, because more patients obviously means more revenue. And I think that's a great care model and delivery model and business model as well. And if we have investors that share that same kind of focus and insight and passion, I think this could be beneficial. And again, I think there are instances where uniformity could be a good thing. If we find out that this media is better than that media, then if you make everybody use the good media, maybe the clinic that's not performing as well will see its values rise. If the weaker clinic doesn't have the same quality of equipment and you invest into it to up the quality of the equipment and the success rates improve, well, then that's worth it, right? So I can see where the investments can be beneficial. But again, like as a physician doing that, my intention is let's improve the quality. But when you're a business, I guess the big question is, what is the final, kind of final goal? is it quality or is it the dollar sign?
Benjamins.
The Benjamins. Yeah. I think it's a great debate, and I appreciate all of you throwing in your 2 cents worth. So
I'm a pharmacist and work in specialty pharmacy. It is
Okay.
100% about sales, unfortunately, which is honestly what turns me off about it.
Oh, see, there you go.
There you
Wow. See, that's an issue.
Yeah.
That makes me worried. Like, is it immoral? Like, should this be something where government should step in? In fact, there were questions being asked by the Ontario government in regards to, what should be permissible in terms of sales of a fertility clinic, because the government is giving us funding for the patients. So if I sell my clinic to a business and I'm selling my funding essentially to that business, which I'm not doing, by the way, so I don't want anyone to take the wrong thing from this. But if I were to do that, a business now owns the government's allocation of funding for a fertility service. Like, is that okay? Is that moral? Is it ethical? Is it appropriate? Where's the line between medicine and business and where they shouldn't meet, right? I mean, there are overlaps. There's no question. I am running a business here. But at what point should you say, okay, we got to draw the line here? This part on has to be made purely based on medical decisions.
That's a great question.
Yeah.
Questions?
Yeah, let's take some questions.
All right.
That was a long
That was good.
a long debate. Thank you all for your input. Let us know how you feel. Put up posts, comments, keep those comments coming. Tell us what you would want.
Hi.
Hello.
35 years old. Is 15 a good AFC?
Yeah, 15 is a very reasonable AFC for anybody. I mean, 15 AFC is decent. You probably get 10 to 12 mature follicles, maybe a little bit less, depends on how well your ovaries respond. And at 35, you can expect 50% of those to be genetically normal. So as long as you're working with a top-notch lab, they should be able to get you a reasonable number of good quality genetically normal or euploid blastocysts. Sure.
Hi, Dr. VNT. I've been spotting about 5-7 days before my period. My OBGYN gave me a referral for a transvaginal ultrasound.
Sure.
He said I could have a new polyp after I had removed one a year ago.
Yep.
Is that a possible reason for spotting or irregular bleeding before my period?
Yeah, sure. It can be structural, so a polyp or a fibroid. It could be infectious sometimes. It can be from C-section scars, or it could be a hormonal problem. So any of those are possibilities. And I'm not sure I'd agree necessarily with a general transvaginal ultrasound. We probably recommend a saline infusion sonohystogram so they can actually see if it's a polyp or not. But yeah, it's a reasonable start to go with a transvaginal. And then if they're suspicious of something being in there, they'll order the SIS to follow. And thank you, by the way, to all of you who have been watching our videos on YouTube. It has gone off the charts with popularity. So we appreciate that. We're now at 10,100 something followers. And almost 1.5 million views. So thank you all for watching. We do have a great video on saline infusion sonohystogram. So if you're wondering about it, go ahead.
What are your thoughts on Neupogen protocol?
Well, Neupogen can be used for a variety of different things. There are people that are using Neupogen in the culture media. There are studies that show it's beneficial and studies that show it doesn't help. We do use it in cases where patients have had previous blastocyst development failure or poor quality blasts. We have Neupogen that can be infused into the uterus for unexplained failures. That is almost certainly beneficial. There's lots of studies on that now. And then there is injectable Neupogen for patients that have complex things like KIR abnormalities and stuff like that. That's very expensive. So it probably does help, but it is quite expensive. So it's something that has to be, closely observed. And, you got to definitely play with how it's administered, because to do it the technical way they want you to, it's $9,000. I don't think that's rational for anybody to be spending on just one medication to improve their chances. But Neupogen in the right venue and for the right reasons, there is evidence scientifically that it can be beneficial. You have to make sure by talking to a very knowledgeable RE or RI, a reproductive immunologist, that it's actually the right treatment for you.
If your patient has successful laparoscopic surgery and endo was stage 2,
Yeah.
do you still do suppression after surgery or
Yeah.
just do surgery if it's successful before an FET?
I would recommend still doing the full suppression protocol. And the reason for that is, even if you have the best surgeon in the world, there's no guarantee they got it all. So there can still be endo left behind, microscopic, that is still causing immune changes in your pelvis. And it's the immune changes that are compromising the quality and the outcomes. So in order to quell the immune part, you really have to turn the endo off, and you can't do that with just surgery. You need the medications to do that. That is my opinion. I can certainly happily advise you that there are undoubtedly people out there that would very, very happily debate that and argue and say no, that that's not the case.
Hi, Dr. V. What are your thoughts on the L-amino acid oxidase test? It's related to implantation issues. Thanks.
Amino acid oxidative tests? Is that what it is?
L-amino acid oxidase test.
Never heard of it before. L-amino acid oxidase test? I've never even heard of that before. Let's look that up. I have no idea what that even is.
Can I share your screen while you search? So people can watch you search.
Yeah, sure. Amino acid oxidase test. L-amino acid oxidase test. Wow, this is getting into Neverland. Let's see what it says here. Flavine adenine dinucleotide containing enzymes that catalyze deamination of L-amino acids, generating ammonium, the corresponding keto acid and hydrogen. Wow. This would probably take me a while to figure out. I've never heard of this test before, nor have I ever heard of its use in fertility, but just reading this first line is very strange. Since LAAO is found abundantly in snake venom, it is postulated to be one of the toxins responsibility for cytotoxicity upon snake bite and venomation. I would need a lot of reading to figure this one out because I am not a snake bite expert, but super cool. We may have to look that. I love the questions about tests, guys, because Receptiva, Era, Emma, Alice, Fertilis is like, there's a lot of tests out there people are touting, and I hate the ones that are fake. So I'm more than happy to check this out.
Hola, Dr. Victory.
Hola, ¿cómo está?
Can endo be on the surface of the embryo without there being an endometrioma? And does excision of endo off the surface of the ovary cause damage to the egg or lower AMH egg count? Why does laparoscopy for endo not help recurrent pregnancy loss but can help infertility if endo can cause both?
Oh, good questions, eh? That's tough.
That's a big one.
So can endo be on the surface of the ovary without an endometrioma? Absolutely. We see it all the time. Can endo, what was the second part of it? Endo on the ovary, and then the second one was...
Ovary can cause damage to the egg.
Oh, can I damage it? Yeah. So surgery can damage the AMH if you don't do the surgery properly, even if you're burning it on the surface. So remember, the eggs are just underneath the surface of the ovary. So if you burn too much of the surface, the thermal damage, which goes 1 millimeter from the best instrument we have and a lot further from the other instruments, will actually spread through the ovary and damage a lot of eggs. So yes, you can damage AMH, FSH, antral follicle count. And then the third part was, why does it not work for? Yeah, that's a great question. There is debate as to whether or not endo impacts recurrent pregnancy loss. That is not definitive. I have seen studies that seem to suggest that endo increases the risk of pregnancy loss and miscarriage, but it's not like that clear cut. So we know that it affects your immune profile. We know that it affects the quality of your eggs. We know that it can affect blastocyst development and implantation and those sorts of things. Do we know for sure whether or not it can affect recurrent pregnancy loss? No. It would be a fairly complicated test to figure out too. So I'm not sure we have a good answer for that or a good way of answering that, but it's a super interesting question. You'd have to take patients that have endo and recurrent pregnancy loss and then do a randomized controlled trial of treatment with Lupron and letrozole for 3 months versus placebo, and then see if they had less recurrent pregnancy loss. And then you'd have to make sure that they were using genetically normal embryos, and it would be a big mishmash. So a complicated study to do. I doubt it'll ever get done, but maybe somebody will try.
When do you do uterine PRP, before an FET for implantation failure, once or twice?
That's up to your clinic. We do one treatment 48 hours before the implantation because that's what the studies have looked at. And as far as how many failures before we do it, we talk to our patients about all of the available options after even just one failure. I don't necessarily encourage everybody to pursue all of the options, or in fact any of the options, after just one failure, but it's very individualized. And I have this chat, thankfully not that frequently because we don't fail that often, but certainly when we do fail, I have it with every single patient. And that chat is, how many embryos do you have left? And how willing are you to make more, right? So if you're 42 and you've got 2 euploid embryos, you need to consider every single option before you do it again, because you may not make normal embryos without doing several more cycles of IVF at that stage. So do I demand that you do stuff? Of course not. But am I going to present you with all of your options? Of course I am. At the same time, if you have 8 embryos and you're 33 and the first one didn't work, I'm going to present you with all the options, but I'm probably going to advise you that I don't think you should do anything different. Just try again one more time because we've got 8 embryos. Not that I want to disrespect the value of those embryos. I consider them sacred and precious, and they're of great importance to me. But at the same time, I don't think there's necessarily that much of a value to doing costly and expensive tests when I suspect that you will be fine with just one more transfer. Whereas if I only have 2 embryos, I can say the same things, but the problem is that if it doesn't work, I've now devastated you because financially you're so much more invested to having to do this again. I don't think finances should make all the decisions, but I think it's important.
Does Canada support short-term disability for IVF, not necessarily for physical reasons, but for mental health reasons?
No, not as a routine thing, but you can speak to your doctor or us, and we certainly look at it, and we have done it for patients that are struggling. Yeah.
Hi, Dr. V and beloved T.
Now you're a beloved.
Bless your heart, bless your soul. What is your perspective on people who may have long COVID going through IVF and transfer? In what circumstances do you consider antihistamines for FET? Thanks.
I'm not aware of any studies looking at long COVID and fertility, so I haven't had any patients with that yet, so I'm not sure I would think it would have that much of a difference, but I guess if you were really concerned, you could do immunological testing and also check for COVID antibodies and your natural killer cell function and cytokine levels, T helper 1, T helper 2 ratios, all of that. With regards to the second part,
Antihistamines?
Yeah, I'm trying to think of how I'm going to answer this. So I've looked up the antihistamine data. First of all, there's virtually none. And second of all, what I did find was very unconvincing. So I'm not on board with the antihistamines yet. If someone does a study, maybe, but until I see someone do a study, I'm not seeing a huge benefit to doing it.
How long after a canceled FET does menstruation return?
Depends on what medications you were on, so that's a really tough question to answer. Natural or modified natural, it should happen within roughly 2 weeks. Stimulated cycle hormone replacement, it gets kind of sticky depending on what they gave you and how much they gave you and whether you got to the progesterone or not, and what they gave you before. So there isn't an answer to that. It's cycle dependent.
What is your reason for doing one Lupron shot on cycle day 21 for FET? I have only found studies that show patients taking Lupron for 2 to 3 months.
Oh, no. If you look up the Cochrane database, they show that taking Lupron to downregulate prior to an FET increases your success rate. So we do it to cycle control so that we don't have to worry about you releasing an egg prematurely. We still do sometimes, but it works most of the time. And that allows me the leeway and luxury of getting your lining ready with relatively low estrogen levels via letrozole without being forced into specific timing because you are going to release an egg. So the reason for that is, let's say your egg gets to a 18 millimeter and it's ready to release, but your lining's only at 5 millimeters, you're not ready for an embryo transfer, and now I'm stuck because your egg's going to release and your lining's not thick enough. So Lupron allows us to manipulate that.
Hello, Victorious Dr. V.
Don't forget.
Yeah, I was worried about the sound, to be quite honest.
Here, let me do it on
There you go,
camera.
that way it looks
So
like it. Yeah.
Tarek's been dying of thirst, so I'm going to open his drink for him. There you go, buddy.
That's great.
Yeah.
Victorious Dr. V and Techie T. Does your clinic do a donor embryo adoption program?
Yes, we do.
Donor embryo transfer?
Yes.
Or does it always have to be through an agency first?
No. We have a donor embryo program. Don't inundate us, please. We don't have loads, but we do have some. And there are always new ones coming up. So, yeah, we have a great donor embryo program. You needed that, didn't you?
Of course. As soon as you answer your question, I take my sip.
Yeah.
That's right. I needed that. For those with autoimmune disease, I have both Hashimoto's grave.
Yeah.
What would you recommend to do before egg transfer?
So autoimmune diseases require you, and again, I can't really answer personalized questions like that for medical legal reasons, but anytime you have an autoimmune condition, it's definitely a discussion with your reproductive immunologist and your 100%. Wow, cool. We definitely want to have a chat with your reproductive immunologist or reproductive endocrinologist. Personally, with patients of my own that have that, I'm happy to explore the possibility of an immune protocol with them because I think it's probably going to benefit them. Having said that, there are studies looking at thyroid antibodies which claim that there is no difference in outcome and so that it can be ignored. There are also studies that show it doubles the risk of miscarriage. So I don't think we've fully figured it out yet. So I am in favor of examining those people closely and making decisions that are right for them on a case-by-case basis. You'd have to talk to your REI and see what they say. Oh yeah, that's right. I was going to, I forgot about that. We've got this nifty little mic. It's called Blue. It's phenomenally phallic, which is awkward, but anyways. So tell us how the audio is. Thumbs up, hearts, whatever. Tell us how the audio is. Write us a note. The audio is better than usual. We're trying to improve the audio videos, so let us know what you think today. Yeah.
What's the impact of STG4 endo on embryo quality in IVF. Had surgery for silent stage 4 endo and niche repair, and hoping we have a better chances of pregnancy now.
So the STG is stage 4 endo?
Stage 4 endo, yeah.
Yeah, I mean, stage 4 endo is obviously the worst stage. So the impact is, if you're doing IVF, there's going to be a lot of inflammation. So those are cases that definitely need to see an expert and consider all of the various options that are available to you. Those options would include things like suppression therapy, Lupron and letrozole, high-dose progesterone protocol, letrozole protocol for the embryo transfer, supplements, NAC, resveratrol, coenzyme Q10, curcumin, ALA. There's all sorts of different things that can be used to improve your outcomes. Immune protocols, steroids, intralipids, subcutaneous IG, there's a whole host of things available. So those are very specific cases where you need deep dive into the whole kind of system and figuring out what is right for you.
They love the audio.
Oh, good. Do they?
Yeah.
Audio is better. Audio is great. Sounds great. I'm seeing that. That's good. Thank you, guys. Thank you, Blue.
There you
Kind
go.
of
There you
freaking out touching it.
No comment. Hi, Dr. V. Thanks to you plus team. I am sitting watching this live with my 4-month-old rainbow baby after 7 losses.
Yeah.
Just want to send you some gratitude.
That's awesome. Congratulations. Woo! Those are the stories I love.
Awesome.
You know what? We talk about this all the time, but the cases that make us happiest, I know everybody thinks it's all about money, but it actually really isn't. The cases that make me happiest are when you come to see me for testing, you do your consult. I give you some basic advice. I tell you we need to do your testing, and you're pregnant before I see you for your testing, for your review. Those are awesome because you spent virtually nothing. Maybe it cost you $100 for the tests or whatever, and you got pregnant naturally. Those are my favorite cases. The only ones I like even more than that are the surgical ones where I operate on people and they're able to successfully conceive. But Tarek and I take a huge amount of pleasure from helping people online. It's fantastic that people are able to learn from what we talk about and then take that and use it and improve their own outcomes. So that's phenomenal. We appreciate that.
Would you transfer a chaotic embryo or a non-informative embryo first?
Oh, well, I'm not sure I'd ever transfer a chaotic, but non-informative, meaning they didn't know if it was normal or not. I'm always willing to take that risk.
What other opinions have you used to prime for IVF to prevent a lead follicle? My doctor is pushing estrogen and I'm refusing. I have endo, DOR, and keep getting a lead follicle. DHA didn't help.
Testosterone and HGH will help you it's not going to prevent the lead, but it's going to help more of the follicles grow together, or just do a duostim cycle. So get the lead follicle, retrieve it, and then, or even ignore it, and then move on to getting the other follicles in your luteal phase. We do that all the time. And the luteal phase cycles, honestly, I do think they are better. I'm starting to look at that and we're going to research it, but I genuinely think the outcomes are better.
Do you use embryoscope for all patients?
Yep. All of our patients get embryoscope.
Hello, Fab, Dr. V, and T.
Ooh, Fab. Have we had Fab?
Fab is new.
We've never had a Fab. That's cool.
What?
We got to start writing these down.
There's a lot.
Yeah,
There's a lot.
We got to keep them. We'll have a running tab.
Yeah, just running over here.
Yeah.
What does a typical testosterone priming protocol consist of? And can you explain why this would be done?
Testosterone? Our protocol, we start 2 weeks before the stim, and it's done for women that have either poor egg yield, so that it'll increase the number of follicles that you can develop, or patients that didn't have a live birth, because there is one study that shows an increase in live birth, or poor blastocyst development, that kind of thing. Yeah, so we start 2 weeks before. There are studies that start a month before, 6 weeks before. We just do 2 weeks. Testosterone's a pretty hardcore hormone. I don't think women should be on it. for that long because there are side effects. So you don't want to be, deepening the voice and enlarging the clitoris and causing all sorts of problems like that.
Would you field the question regarding tubal reversal?
Yeah, of course. Fire away.
There you go. Elena. What is the...
Oh, that was the question? Yes. Answer any questions you want on tubal reversal. We actually, years ago, it's probably 2.5 years ago, we did a show, and it's on YouTube, on the comparison of tubal reversal to IVF. In some cases, the reversal can be just as successful. So I'm not opposed to it. In fact, right behind Tarek, where you guys cannot see, is the equipment I use for tubal reversal. These crazy expensive goggles with Zeiss lenses that let me see what I'm doing.
For hunting, they have scopes made from Zeiss lens as well.
I'm not hunting people's tubes, dude.
Yeah, I know. I'm just letting you know. Like these guys are in the lens business.
They are in the lens
There's no lens
business.
they don't touch.
Microscopes, everything.
Yeah, everything.
Yep.
They're very expensive.
They make IVF microscopes.
Really?
Zeiss does, yeah.
They're very good glass.
I got Olympus, I got Nikon. Maybe the next one will be a Zeiss. You never know.
It's expensive.
Well, I think it's psychotically expensive.
It is
Well,
expensive.
not that these ones. A microscope for an IVF lab is about $120,000. Yeah.
For the microscope.
With all the gizmos for the ICSI,
Yeah.
when you put it all together, it's like 120 grand. Yeah. Almost had a heart attack.
I appreciate that you admit when you don't know something. It says a lot about you, so thank you.
Oh. You know what? One of the best things about doing this show, I appreciate that comment very much. One of the best things about doing this show is I learn from doing this show. Like, anyone that claims they know everything is actually a fool. And I certainly am trying very hard not to be a fool. So there is no question that there are many things that I've learned from people in my practice and things I learned from the show. Fertility, which I admittedly love, great company. They do great work. They're saving our patients thousands of dollars. I get lots of responses, and I think it's beneficial. I didn't know about them. I learned about them from one of my patients who I love very much. Her nickname is C, and she's actually in the SIS video.
Yeah.
So she told me about it. I learned about it from her, and she's amazing, and I adore her, and she's wonderful. I learned about that from her. I had never even heard of it before. I go to conferences, I read nonstop, but there's no way you're going to know everything. It's impossible. I was scanning through the 6 journals I normally read. There weren't any interesting articles. So then I went to 2 other journals I don't read that often. There were some new articles, so now I got to go through those journals regularly. There's no way to keep up with all of this. No one can do that and have a practice and be a husband and a father and a religious guy and, all the other things and have some kind of social life. It's impossible.
It's very challenging. There's more. What I want to go to the girl that asked the question. Here's the follow-up. So my fiance had a tubal reversal surgery. Her left tube was fixed, but unfortunately 4 months later an HSG showed it was closed.
Oh.
Our doctor said it was a distal block. Can those be unblocked? Her tubes were ligated using the Pomeroy technique.
Pomeroy.
Yeah, we are now using IVF, and my fiance has PCOS. Day 9 of stims today, and she has about 14 follicles, and her estrogen level is 1350. Is this response considered poor for a PCOS patient?
It's day 6. Which day of stims?
Day 9 of stims. Day 9 of stims.
And there's
she has
14
about
follicles?
Her estrogen level is 1350.
I don't know. I'm assuming you're using US units, so that's not terrible. It's probably a little on the low side for a PCOS, but it's not terrible. With regards to the, I don't know. Yeah, I think that's reasonable. It's not amazing. I mean, it depends on how PCOS she is, what her dose they gave her was. All of those things can make a big difference. So that's all stuff I would definitely need to look at. And again, I need to know the units that you're using. So that's kind of critical as well.
Would you be concerned about giving a woman letrozole to help with ovulation when she
Oh, you know what? Hang on one sec. I got to answer the first part of your question.
has ovarian?
Distal occlusion should not be there if they put the tubes back together, because when I do a tubal reversal, I flush dye through the tubes to make sure it goes through and you know the tube is open. But if it is occluded distally, then it can be broken open by an interventional radiologist. They can pass a wire with this tiny little ball on it on the end through the tube and break the adhesions open. It doesn't always work, but they have studies that show about a 40% success rate, so it is possible. Okay, sorry. Letrozole?
Yeah, letrozole.
Yeah.
Would you be concerned about giving a woman letrozole to help with ovulation when she has an ovarian cyst? All one word.
Depends on the kind of cyst. So I'd have to see you and see what kind of cyst it is. Some cysts, you don't want to stimulate patients because they may need surgery. Other cysts, it would be fine. So it depends on what kind of cyst.
I just want to say thank you, Dr. Victory. You're the best. Thank you for your dedication to fertility. Another comment that says, you're the best. You helped me so much, and I wasn't even your patient.
Oh.
I believe everything you
I love
do
those
and
ones.
tips you give is what has helped me succeed in IVF. Thank you for all you do.
That's awesome. Those are great, eh?
100%.
Like,
That's, you take
I
that
don't know
from
about
there.
you, but I leave from here and
I fly
yeah,
sometimes.
it feels good. It definitely feels good. We did something good today.
Yeah, for sure. For endo patients who did excision surgery and 3 months of suppression,
Okay.
do you usually recommend a modified natural transfer with letrozole or medicated protocol for FET?
Oh God, no one with endo, in my opinion, should ever have a medicated protocol. It just makes no sense. Estrogen fuels endo. A medicated protocol is usually high dose estrogen. Why would you fuel the endo that you just suppressed or surgically removed by feeding it the estrogen? It's so counterintuitive. I don't understand why anybody would ever endorse that. Ever. It just doesn't make sense.
If your patient did only 10 weeks of suppression for endo for personal timing reasons
That's fine.
and did a lap surgery already, would you be comfortable still doing an FET after
Yeah.
10 weeks of suppression?
Yeah, absolutely. I don't think we have to be sticklers that much. Somebody showed me an article recently that I actually hadn't seen before where they used Lupron and letrozole for 2 months instead of 3, and they also showed a benefit. Now, I'm still sticking to 3, but yeah.
When do you do an interlipid infusion prior to FET?
5 to 10 days before the FET, the day of the FET, at the positive beta, and then every 6 weeks. Carly has some questions for us.
Yeah. Well, hold on. We have one before Carly.
Oh, okay. Because we're past 9.
Yeah.
And our food's getting cold.
that got cold a while ago. Someone with KIRAA and partial HLA-DQA, is LIT necessary or is SCIG sufficient enough?
So for the KIR, they're saying we should use Neupogen. For DQ alpha, sub-QIG, if you're a partial, should be enough. So, yeah, LIT, not necessarily going to help you in those situations.
If silent endo is suspected, A, does it have any impact on low progesterone, a natural cycle post-trigger? B, would you test after 4 failed transfers at this point?
A, silent endo can affect progesterone levels because we know that there are women that have progesterone receptor abnormalities when they have endo. So yes, that's a possibility. And B, I would never let anyone go 4 failed embryo transfers without testing them. I literally wouldn't let someone do that. So yeah, I would have started testing for various different things after failure number 2. In our program, if we fail 2 embryo transfers, even 1, I'm telling people, here are your options, but 2 for sure, I'm telling them they should check because there's probably something wrong if we haven't succeeded within 2 tries.
Would you be concerned about giving a woman letrozole to help with ovulation when she...
You asked that one.
Oh, that's interesting.
She asked twice.
They go over. They travel. LIT isn't intended for partial DQ alpha match?
It can be, but sub-QIG will override the LIT, and it's cheaper in Ontario.
Will I need to do fertilizers after DNC or can I skip that?
Yeah, I think you may want to do the Fertility, but we can talk, Carly, because as with any patient, this is not specific to you. It depends on how many embryos you have and whether you want to try or do testing first.
What are subchronic hematomas more common in IVF? Why are subchronic hematomas more common in IVF?
Oh, yeah. If we figure that one out, that's probably another Nobel Prize winner for us. I don't know. I mean, whatever process has led to your infertility probably has a vascular impact, a inflammatory impact, an immunological impact. Many of our patients are on aspirin. That probably does increase your risk of developing an SCH. So there's a lot of different reasons for it. I don't think I'm ever going to be able to answer that fully for you, but they are quite common. We do see them a lot. I don't worry about them unless they're enormous. Or you're persistently bleeding. And always remember, no bleeding in pregnancy is normal, so you should be investigated. And for those of you who are Rh negative, please go get checked, because if you're past 6 to 8 weeks, you likely will need RhoGAM.
Last question.
Tarek's terminal.
Yeah, we could do that. Sure.
Okay.
Dr. V,
Yeah.
what are your thoughts on segmental LLM? Does
Low
your
level
clinic
mosaic.
transfer
Yeah.
HLMs?
Yep. We don't transfer high-level mosaics, but we do transfer low-level mosaics, regardless if they're whole chromosome or segmental, because the studies show that there's a 50-50 chance those will result in a normal pregnancy. So we are transferring those. I just had a great meeting yesterday with a genetic counseling team. Here's another example of how we will take a hit on finances potentially to include services that are better. So I met a lovely young lady and her team who have started a genetics counseling service. Very comprehensive, some top-notch people. And they are kind of interested in counseling for all of our patients. And I think it may be worthwhile to have that. So we may include them by having us pay for their services rather than passing the charge on to you. And I emphasize may because I have to see how much it costs. But we may include them in part of our package and our bundle. And then everybody would get genetic counseling so that when you get a case like a low-level mosaic, it would be available, to you and have counseling available. My lovely bride is tapping me, telling me to call her when I come home. So I think we're going to cut the show off there. I hope you guys all have a wonderful evening. Next week, we will talk about the value of intrauterine infusions, PRP, HCG, Neupogen, and peripheral mononuclear blood cells. So we will be in touch again next week. It'll be Tuesday, as far as I know, at 8 o'clock. Join us. Let us know what your thoughts were about the show. Comments, lots of likes. Make sure you tell us what your feedback is. And as always, if somebody knows how to grow on Instagram, I am all ears, because we cannot grow on Instagram. I think they literally hate male physicians. But anyways, that's just me. Jessica, go to bed. Have a good night, guys. We'll talk to you soon.